Good morning, good afternoon, everyone. This is Sume Ndumbe-Eyoh with the National Collaborative Center for Determinants of Health. Thank you for joining us today. We are here today for the webinar, Race and the Social Determinants of Health and Health Equity. This is a second of a two-part series on the importance of racism on the social determinants of health. Today we'll be focusing on organizational and systemic approaches for achieving racial equity. If you're participating today by phone only, you should have received a backup PowerPoint slide. Please use that to follow along the presentation. During the course of the webinar, I would like you to share your thoughts, your comments, and any resources that you have with us as well as other participants. You can do so in the chat box. I see a number of people already introducing themselves. It's really great to have you all here today. At the last count, I believe we had about 270 people registered for today's webinar, so this would be a really nice opportunity to find out what others on the line are doing related to racism in the context of public health practice. Please also note that today's webinar, including the chat box, is being recorded and will be available on our website shortly after the webinar. As I mentioned, my name is Sume Ndumbe-Eyoh. I am the Senior Knowledge Translation Specialist with the National Collaborative Center for Determinants of Health. I am joined today by my colleague Danielle McDonald, who's our research assistant, and you'd have received a number of emails from her prior to today's conversation. If you're having any trouble connecting to the call, you can send her an email, which will be on the slide deck or in your email. She may not get back to you very quickly. She's getting a lot of requests, but she'll do her best to address any questions and concerns you'll have. Thank you, Danielle, for being here today. It is an immense pleasure to have our guest presenter with us, Dr. Onye Nnorom. Onye's passion for public health arose from her own experiences. Born to Nigerian and Trinidadian parents, she is particularly interested in immigrant health and Black community health and wellness. A lecturer at the Dalla School of Public Health and the Department of Family and Community Medicine, Nnorom is Associate Program Director of the Residency Program in Public Health and Preventive Medicine, and also the Black Health Team Lead for the Faculty of Medicine. On slide 4, you can see a number of things that she also occupies her time with. So thank you so much for being with us today, Onye. The National Collaborative Center is part of a network of 6 NCCs, and all 6 NCCs are funded by the Public Health Agency of Canada. We have a shared mandate, which is to make public health programs and policies more effective by increasing awareness of new and existing knowledge, and we think about knowledge broadly, both as research-based and also experiential and practice-based. We also do so by identifying and helping to address public health priorities, collaborating with established public health networks, and also helping to identify gaps in knowledge and relevant applied research. Each NCC has a specific area of focus in public health, so our work spans Aboriginal health, environmental health, infectious diseases, methods and tools for knowledge translation, healthy public policy, and our particular focus, the social determinants of health and health equity. So before I continue, I'd like to acknowledge that the National Collaborative Center for Determinants of Health is located in Mi'kmaq, which is the ancestral and unceded territory of the Mi'kmaq people. I honor this land in recognition of Indigenous resistance and also as a call to us all to remember our responsibilities as treaty people. This responsibility, amongst many other things, calls on us to pay attention to ongoing colonial processes and, more importantly, to work towards undoing the growth inequities which exist in our society today. As I mentioned, our focus at the NCCDH is on the social determinants of health and health equity. So we work with public health practitioners, decision makers, and researchers across Canada. So thank you all for joining in today. And we work to translate and share evidence to help influence the social determinants of health and health equity. We really focus on a broad range of projects. So in this year and the coming months, some of the things we're working on, obviously racism and public health. We're also doing work on organizational capacity development, some work on population health status reporting. So if you're interested in pretty much almost everything on health equity related, you can check out our website for more information. The information we have on our website goes beyond our own work because we do share resources which are produced by other organizations both within Canada and way beyond. So before we go any further, that's a little bit about us. We'd like to find out who you are and where you're joining in from. If you've already introduced yourself, thank you very much. This is a chance to tell us where in the country you are calling in from. And if you're not in Canada, you can also let us know that. Thank you very much. Thanks, Danielle. Great. In the chat box, I see we have folks from Manitoba, Alberta, Edmonton, someone from Public Health Ontario. Thank you. I see some more Edmonton folks. Excellent. Thank you so much. So we have folks from Ontario. Let's see, Manitoba, Saskatchewan, BC, Nova Scotia. Excellent. It's great, really great to have you all on the call today. Thanks, Danielle. So our objectives for today's conversation are to discuss approaches to integrate anti-racism in policy and decision-making. We'll also be sharing examples of anti-racist organizational transformation and really briefly highlighting the importance of measuring systemic racism in public health. I'm getting a little note that I may be sounding a little bit muffled. I apologize for that. I'm going to do my best to be a little bit louder, and hopefully that helps. Okay, so in the first part of the presentation, I'll be discussing approaches to integrate anti-racism into policy and decision-making. And in the second half of our presentation, Onye will really be talking about those examples of anti-racist organizational transformation and also touching on the other two objectives for today's conversation. So before we go any further, I'd like to get a sense of what kind of work your organization is currently doing related to racism in health. So do you currently have any policies or practices? Do you not? Is this something which you're thinking about, or is this not on your radar at all? Excellent. Thank you. Great. I see about 45%, somewhere around 40% of people have some policies and practices. That is really encouraging to see. For those of you saying yes, you can, if you want to share that with us in the chat box, that would be really great. If you have resources which are publicly available, please do share those also. So there are a few people where it's not on the radar, but we're really glad that you're here because I think your participation in today's webinar will hopefully help push your organization a little bit further along. So I'm on to slide 11 right now. So as we know, racism is a system which advantages and disadvantages based on race. We're not going to spend a lot of time today talking about what racism is or isn't. In the webinar which we hosted in October, we really did a lot of that, defining what racism is and really trying to help us understand that. If you missed that webinar, we do have a recording available on our YouTube page, and the link is included in slide 11. You can also check out our Let's Talk Racism resources we released earlier this summer. So if we think about racism as a system which advantages and its disadvantages based on race, then what are we here for? What is our goal? So I really think that our goal is moving towards racial justice, which is the systemic and fair treatment of all people that results in equal opportunities and equal outcomes for everyone. So really the end goal here is getting to a point where regardless of what race, and I'm using race in quotes here, you're defined as, your opportunities are the same, and the outcomes that you experience in health and a wide range of social issues are the same. Really we'll be talking about anti-racism as an action-oriented strategy which can help us move in that direction. So I think about anti-racism really not as one strategy, but as a wide range of approaches which we can bring to our work when we think about racial justice. The key features to me when I talk about anti-racism is that anti-racism really is action-oriented, so we are doing something very proactive to change the current situation which we exist in. It's both an educational and I think more importantly, a political strategy which focuses on political and systemic change. Anti-racism addresses issues of racism, and in doing so we also look at how other systems of oppression like gender inequities or income inequities interact with racism. So when we think about racism not as a standalone bit, but also looking at it as in terms of how it is influenced by other systems. So today I'm going to be talking about four really broad, broad themes. I'm going to start by talking about public health critical race practice as an approach or a framework which can help us really address racial health inequalities. Okay. So I'm hearing that we're still having some issues with the sound. Just give me 1 second, and I'll see if we can do a minor adjustment here. Thank you for your patience. Okay, so I'm hoping that is a little in the chat box. That would be great. All right, thank you. Okay, great, thank you. So as I mentioned, I'm going to be talking about public health critical race practice. I'm also going to introduce the idea of choice points, so this really critical points of decision making, as well as talk about some broad areas for action, and then close with talking about racial equity impact assessment as a tool which can help us in our policy and decision making processes. So beginning with public health critical race practice. So if we think about practice as a combination of what we know and what we do, the framework we see on, or the model we see on slide 13, which has been proposed by some researchers from the States, really talks about race consciousness, the awareness of race as a way of organizing, and we talk about 4 different areas of focus, as well as 10 principles related to this. So I'm going to begin with the first one, which is the idea of thinking about the ways in which race plays out in society today. And with that, we really think about racism as something which is central to experiences and to how society is organized. A lot of the times when we talk about racism, we sometimes talk about it as something from the past. We talk about it as history. When we talk about colonization in Canada, we sometimes talk about, when we do talk about this, for starters, we talk about it as something which has ceased to exist. This model is really calling us to think about racism as not as something of the past, but as a system which really influences everyday decisions, both on a micro level, so in interactions between people, but even more importantly, on a macro level, so in terms of how our institutions and our societies are organized. So that's the idea when we think about race as a central way in which we organize our lives. And related to race as something contemporary is the idea that race is a social construct, so it's not a biological reality. I think for those of us who work in health, that's a really important thing to keep in our minds, because we tend in health to really have this biological focus on disease and on health. But if we think about race as a social construct, then we can be clear that the inequities we see across, say, Black people and white people, it's not something natural. It's not something which is just supposed to, something which exists because of the decisions we have in place. Another bit related to race being contemporary is that it's ordinary, it's everywhere, it affects everyday business. Someone's line is open. I can hear some background noise. Can you please just press star 6 to mute yourself? Thank you. And then it's star 6 to mute your line. All the lines should be closed, but someone may have opened your line. Thank you very much. I think the background noise is... So I was just talking about the first focus of this model, which is really thinking about how racism plays out in today's society. I'm going to move on to the second bit, which is talk about knowledge production. And here we're talking about racism, about how we come to know what we know, and the kinds of approaches we bring to our work. So here I'm going to highlight the biomedical focus which we tend to use in health. Now, if we think about what knowledge we're producing, how we are producing that, so how do we collect our data? How do we measure? How do we analyze that data? What don't we collect? So right now we know that in the Canadian context, there's a real dearth of information and hard data on racism and health, or racism and education, because it's not something which we routinely collect. There's still a lot of reticence to actually ask those questions and ask why do certain racial groups experience higher rates of inequity. So let's really talk about how we come to know what we know. So we seem to be having a lot of issues with sound today. Am I still on? Okay, yes, I am. All right, so someone said just on mute. All right, thank you for that. And apologies for the sound issues which we seem to be having. Thank you all for your patience. All right, great. So I was talking about knowledge production. So the ways in which it's really important for us to be able to collect the appropriate data and then analyze it. So we have cases in history where data was being collected on race, and the conclusions we made then would be, so let's say we will look at, I'm going to pick a random public health example, breastfeeding rates across racial groups. Now, you can say that some groups have higher rates of breastfeeding than others. What conclusions do we then draw from that? Do we draw conclusions to then promote racial equity, or do we fall back to racial stereotypes to explain those differences? Now, if we remember that race is a social construct, and that the inequities which we see amongst racial groups are based on our policies and everyday decision making, then we can start to develop different kinds of policies. So related to this is the idea of conceptualization and measurement, which is focus number 3. It is the circle on your right-hand side of your screen. So here again, we're saying that when we do measure, we're measuring race as a social construct. And in doing so, really thinking about how our social and our social environment are impacting the outcomes we see. Related to this is the idea of intersectionality. So complicating our analysis and not just looking at race on its own, but also looking at race at the intersection. So an example of that is in our reporting, are we just reporting, say, rates of diabetes for men as a group? Or are we breaking that down and thinking about how race plays out? Indigenous men, Asian men, to really deepen that analysis, and then adding, well, including income-related indicators with that analysis. So it's really important that as we measure, we think about race as a social construct, and also complicate our analysis, so not look at race alone, but look at how people who are differently positioned, so how our social locations, how people experience policies and practices, and also the observed outcome. The last bit is really talking about action. So at the end of the day, as we explore these areas, we have to focus on doing something with the information which we get. So I'm on focus number 4, which is the bottom bubble on your screen. So here are really 3 things. So bringing in, again, critical approaches, being open to critique of how we do our work as a field. So if we think about critiques of public health as highly paternalistic, so we're a lot of times just telling people what to do, and how does that work when we're trying to address racism? Again, we're bringing intersectionality and voice. So I want to spend just a little bit of time talking about voice. And voice is really bringing that idea of social location and asking ourselves, are the people who are impacted by the decisions we're making, are they at the table coming up with the solutions? So here it's really important to place the voices, experiences, and the leadership of racialized and indigenous people in terms of how we develop our policies and our practices. You can explore the model in more depth in the paper. You'll see a link at the end of my presentation. But I think it's a really helpful framework. It can be used on its own or also in conjunction with other frameworks and tools. I'm going to move on to slide number 14. So if we think about it, I just introduced the public health critical race practice model. So now that model sort of tells you how to approach the work. We can think about where we can then change. What are our levers of change as we start to explore anti-racism work? I'd like to policies. followed by social and institutional practices, and finally cultural representation. So by public policies, I'm referring to the laws which directly allocate public resources, or also those which indirectly influence how private resources may be distributed. And we're here really exploring how they may have a greater or negative impact on communities of color and indigenous people. So some examples of that could be how the educational system is funded. So do schools with more people of color have less funding? The answer, if you're in Toronto, is yes, they do. So that's an example of how laws or practices can distribute resources in ways which negatively impact certain racialized communities. So we talked about social and institutional practices. So these are the ways in which the racialized ways, or sometimes the colorblind ways in which our institutions, both public and private, function to generate racially based biased outcomes. I normally live in Toronto. I'm not physically there right now, but in Toronto, as an example, there's been a lot of work talking about how in law enforcement, the police actively targets racialized communities, particularly Black and Indigenous communities. Right? So on file, the police have absolutely no policy saying that we're going to target racialized communities, but in practice they do. So if that's a U.S. institution, how do we surface those kinds of practices and bring them to light so it can create alternatives? Speaking of cultural representation, here we're thinking about the language we use, the images, the narratives, sort of the stories we tell ourselves as a society, and really this builds up our conventional wisdom around race. So think about, if you'll close your eyes with me for a second and you think about a criminal, who comes to mind? You think about someone helpful, who comes to mind? Now imagine whoever you thought about walking into your practice as a public health practitioner. How does that conventional wisdom influence your interaction with them? How does that influence your policies and practices? So an example of that could be the ways in which the media portrays certain neighborhoods as inherently dangerous, and as and the young men in them as dangerous too, or ideas about who is hardworking and who is not, or who can excel academically, or who can excel in a workplace, who can excel as a leader. So all those ideas then influence the decisions we make on a daily basis. So they really influence our common sense ideas then influence public policies and practices. So I think if we realize that we have this opportunity to intervene, we then also have opportunities to make a difference. Here I'm introducing the idea of choice points. And choice points is really thinking about how we have different opportunities in our everyday practice to make decisions which can influence outcomes, both positively or negatively. Here I want to talk about the positive decisions which we can make in our everyday practice. I'd like to focus on choice points for institutions. So we're all individuals, the things which we can do in our daily lives to make a difference, and you can read that on your own. As institutions, we can think about changing our planning, our budgeting, how we hire, so who works within our institution, as well as policy development and our routine practices. And these are all opportunities to influence what we do. So I'd like to stop here for a quick second and ask you in the chat box to think about, in your daily work, what are some decision-making points that can affect racial equity outcomes in your work? All right, thanks. I see a few people writing in here. So the question is, in your daily work, in your organization, what are some decision-making points that can affect outcomes? Perfect. So keep sending those in as we move on. So someone is talking about, Julie Hill mentioned a lack of disaggregated community health assessment as an opportunity to change decision-making. Thank you. Michael is talking about funding allocation. Michelle is talking about the lack of data to drive decision-making, hiring policy excellence. So I think those are really great examples of how we can make a decision. So if you are in a position to hire, how in that moment do you make a different decision which can promote racial equity? On slide 18, there's some more questions which you can explore at the end of the webinar to help with that. So really thinking about how your decisions and your actions may be reinforcing the status quo and thinking about the kinds of actions you can take to support and advance racial equity. On slide 19, these are 15 good ideas from the Wellesley Institute, and these are really excellent policy and program areas, which is very appropriate for public health organizations to intervene in. For the purpose of today's presentation, I'm going to focus on one specifically, which is the use of race impact assessment for the development of policies. And on slide 19, it is the fourth item there. I'll encourage you to explore the other 14. A number of people have mentioned things like the importance of collecting data. People talked about the workforce. Those are really important areas of action. So I'd like to introduce some racial equity impact assessments as systematic examinations of how different racial and ethnic groups may be affected by current proposals or decisions. So I think ideally you'd want to use a racial equity impact assessment at the beginning of a policy or program. So before you make any final decisions, really in the developmental phase. Now that said, there are always opportunities to use them in the course to apply them to existing programs. I want to highlight two really positive examples which are actually enshrined in legislation. The first is the United Kingdom for a while has required that government agencies use racial equality impact assessments. They talk about this as a way of systematically and thoroughly assessing and consulting on the effect it's likely to have on people depending on their racial equity group. In their opinion, the main purpose of this is to preempt the possibility that the proposed policy could affect some racial groups unfavorably. A second example, which is in the Canadian context, is in Ontario, the newly passed Anti-Racism Act, which was passed in the summer of this year, also requires the use of racial equity impact assessments. There currently isn't a tool, but I believe that tool is in development, but those are really positive developments in the Canadian context. So I'd like to close before I pass it on to Onye, just with some closing thoughts. So I just mentioned the use of racial equity impact assessments, and in the past when I've talked about this, I've heard people talk about the fact that they're already using health equity impact assessments, and I call that a detour. So I think in our work on anti-racism, we need to be mindful of the detours. I think it's really important that when we want to do anti-racism, decolonial anti-racism work, we courageously and boldly stare at the problem, and the problem is racism and colonialism. And what happens is when we use generic tools like health equity impact assessments, those issues tend to be buried in the conversation. Also, I think as organizations, it's important to dedicate the appropriate amount of resources and commit to this in the long term. So this is not easy work. It's not going to be done in a day. But I also believe very strongly that it is work which is highly doable and that there are lots of resources available to help us in our work. But as we do this work, I think we need to be committed to ongoing learning and a willingness to risk, knowing that even with our best intentions, there will be resistance along the way. There rarely ever isn't, but that is just part of the process. And I do believe that at the end of the day, we are all better off. So Indigenous peoples, racialized peoples, and white people are all better off when we do take an anti-racist approach to our work. So to Onye, we will, if you have questions, you can drop them in the chat box. We'll be taking questions and comments at the end of the presentation. Thank you. So Onye, on to you. Onye has been talking, as I mentioned today, about transformational organizational examples related to racial equity. Thank you.
Thank you, Sume. And so I'd like to thank the NCCDH for inviting me to speak to you today, and thank you all for dialing in. First, I'd like to begin by acknowledging that the land where I live and work is in the traditional territory of the Haudenosaunee, and most recently the territory of the Mississaugas of the New Credit First Nation. The territory was subject to the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. This territory is also covered by the Upper Canada Treaties. Today, the meeting place of Toronto, from the Haudenosaunee word Toronto, is still the home to many Indigenous people from across Turtle Island, and I'm grateful to have the opportunity to work and live in the community on this territory. So before I begin, I'd like to provide some context around my interest in anti-racist approaches to improve population health. The photo on the left is of me in grade 3 in Montreal. By that time, I had already experienced racist macro and microaggressions, including being called the N-word and feeling excluded. I already knew that some teachers had and would continue to have unconscious racist biases about my academic ability. But I was able to thrive, as you can see in this photo. I am smiling, because despite the occasional racist experience with individuals, my school was a supportive environment where multiculturalism and inclusivity were promoted. But for many of the Black children that I grew up with, they were not so fortunate. And many of them, young and talented, were discouraged by the effects of systemic racism. They experienced discouraging teachers in the educational system. Some were the targets of the child welfare system, or were the targets of over-policing when we got to high school. And for others, and I'm saying even those, as youth who never got into trouble, never any issues, the job market was another uphill battle for them. A recent study from McGill University, based on census data from 1996 to 2006, showed that Black university graduates had higher unemployment rates compared to non-Black high school dropouts in Montreal. When I read the statistics that Black and Indigenous children in Ontario were over 40% more likely than white children to end up in foster care, and in Toronto, Black children are almost twice as likely to drop out from high school, it's not surprising to me. For those of you who have not experienced systemic racism, let me tell you that it can have profound effects throughout the life course. It is harmful to the health and well-being of racialized communities and our society as a whole. Now, I was fortunate to be given a voice that I used to speak out about racism as early as elementary school. And now as a public health physician, I'm committed to addressing systemic racism and the development of supportive environments, which we know can impact health here in Canada. So getting into the main part of the talk, I just wanted to put this slide as a reminder of the objectives for today's session. I will be touching on each of these topics, but my main focus is on our organizational transformation. And this is my outline of what I'll be covering. So first, I'll give a brief review. It was covered in the previous webinar, and also Sume touched on some of this, but systemic and institutional racism and why this is important. I think it's important to also mention that I do use the terms systemic, structural, and institutional racism interchangeably. This is common in the literature, and I have a tendency to do this too. But the next piece will be around going beyond education and really organizational transformations. And I'll cover some approaches, examples, and tools. So first, a definition. So earlier this year, the Wellesley Institute here in Toronto proposed a new definition for institutional racism, which I really wanted to share with you because it's essentially a call to action. They state, institutional racism is an ecological form of discrimination. It refers to inequitable outcomes for different racialized groups, and there is a lack, where it occurs, there is a lack of effective action by an organization or organizations to eradicate the inequitable outcomes. Essentially, institutional racism is seeing racial disparities and doing nothing effective about them. So it's essentially a call to action, and I urge you to share this with your colleagues because it really is a great definition and a great resource. So, but why should we be addressing institutional racism? Why take this call to action, particularly in public health and in the health field? So the first reason, using a public health lens, is because racism is a social determinant of health. And I didn't make that up. It's not my own idea. This has been acknowledged in Canada by Toronto Public Health and the National Collaborating Centres for Aboriginal Health and Determinants of Health, as well as other organizations. I created this diagram as a way of conceptualizing the pathways through which social influences can lead to racism and consequently poor health outcomes. So on the left, under social influences, we must take into account our history, and Sume alluded to this as well. For example, colonization and residential schools for the Aboriginal population, Canadian slavery for the Black population, and racist immigration laws for racialized populations in general. Today, we are also influenced by messages we receive from the media, music, movies, and other forms of entertainment about racialized groups. These can lead to intentional and unintentional forms of racism, as we see in the middle, that can occur at three levels: the individual level, interpersonal level, and systemic level. And although, the interpersonal level, which is where one person says or does something racist to another, is what usually gets media attention. So that's usually what gets our attention. That's what we think of when we think of racism. It's actually what occurs at the systemic level that has the greatest population impact. I'm referring to the laws, policies, and organizational cultures that systematically disadvantage people of color. This can lead to poor health outcomes, seen on the far right, that are directly and indirectly due to racial discrimination. For direct, poor health outcomes can occur independent of other social determinants of health, in particular independently of socioeconomic status. There is a growing body of peer-reviewed literature demonstrating that racism can act as a type of chronic stressor, affecting hormone levels, the immune system, and other physiological processes, and increasing one's risk for chronic conditions such as hypertension and also mental health conditions like depression. There are also what I categorize as indirect pathways, where racism can lead to poor health through loss of opportunities, essentially leading to poverty and other forms of social deprivation through the other social determinants of health. For example, a 2011 study by the Wellesley Institute called Canada's Color-Coded Labour Market reported that a racialized person earns 81.4 cents for every dollar a white person earns. There are income inequities based on race in this country, and so we need to come to terms with that in Canada. And of course, we already know that income is one of the most significant determinants of health. So we really have to take that lens when we're thinking about racism, especially systemic racism. Furthermore, the other reason we should address systemic racism is because, honestly, the United Nations has flagged that this is a national problem. The United Nations Working Group of Experts on People of African Descent who visited Canada in the fall of 2016 have essentially said that Canada is racist. To quote them, they state that they are deeply concerned by the structural racism that lies at the core of many Canadian institutions and the systemic anti-Black racism that continues to have a negative impact on the human rights situation of African Canadians. They emphasized the fact that disaggregated race-based data collection is required in order to identify racial disparities for all groups. So given these reasons, hopefully I've convinced you, and if you've dialed into this webinar, you probably understand these issues as well, then what can public health organizations do to address racial inequities? So this is I put a snippet up here of an article published in the Lancet recently by public health researchers from Harvard. In particular, Nancy Krieger is one of the authors. Many of you might be familiar with her work. And they propose 3 interventions for racial health equity. So one is reinvesting in racialized neighborhoods. They propose doing this through multi-sector partnerships, so public and private, to achieve community-specific changes. The second is advocating for policy reform. So they give the example of changes to prison sentencing, which disproportionately affect specific racialized groups. And I do want to flag that that is not uniquely an American problem, but also is an issue here in Canada, where Indigenous and Black population is overrepresented in our prison system. And third, they propose health student and health professional training on anti-racism, and they highlight not just cultural competency, but anti-racism, structural competency, cultural safety, and humility. So I recommend this paper if you have an interest in evidence-informed health equity work. But the gold standard, of course, would be organizational transformation. So I've begun an environmental scan of organizations undergoing system change to address racial equity. My observations I've shared with you as far as key elements. The work is ongoing, but at least I was able to identify first that for an organization, there has to be an element of recognition of the effects of racism. So a phase where the organization engages in listening, engages in the community, and for some organizations it has involved community and institutional healing processes, but really recognizing the deep structural violence, intergenerational trauma that is caused by systemic racism. Other key factors are strategic planning and change management. So these approaches have frameworks that are beyond the scope of this talk as far as general strategic planning and general change management, but there are a number of frameworks that you can find for those elements. And then finally, the collection of data, both internally, so staff, and externally, so with regards to clients, patients, or the public. And essentially, this has to happen internally with the staff to be able to talk about not only providing demographic information, but their perceptions on race and racism, as well as the communities that are served, essentially because you can't manage what you don't measure. And so collection of data is an essential piece of this. So what I wanted to share with you, though, as far as frameworks, is a really great one by the Government Alliance on Race and Equity in the United States. They've got a really great resource, and I put the details at the bottom of the page, called Racial Equity, Getting to Results. And they have a 6-part strategic approach to institutional change to address racial equity. And so it's divided into 3 parts: normalize, organize, and operationalize. So under normalize, they recommend using a racial equity framework, operating with urgency and accountability. Under organize, build organizational capacity, partner with other organizations and communities. And then finally, under operationalize, implement racial equity tools and be data-driven. So I'm going to give you some examples of organizations that have applied these approaches, not necessarily in this order. So they might not have used this exact framework, but the elements that are listed here were included in their approach. So I'm going to walk through it with you using this lens. So the first example that I wanted to share with you is that of the Boston Public Health Commission. For those who might not be aware, Boston is a racially and ethnically diverse city in the United States, where less than 50% of its residents are white. And in 2012, 26% of the Boston population was foreign-born. So a really diverse city. So in 2008, Boston Public Health made a commitment to address racism in the organization and the community. And again, there's a great resource here where they actually report on their racial justice and health equity initiative. So that link is there for you at the bottom. So the first part of the framework they started with the organized part of the framework and decided to build organizational capacity. They formed an anti-racism advisory committee, which reviews, assesses, and develops recommendations on internal policies, practices, structures, and systems using a racial justice and health equity framework. And they also work closely with the senior leadership team in all project areas to ensure leadership support and collaboration. And I really do want to highlight this. I know that, for many of us, there are things that we can do, and the choice points that that Sume mentioned, where we can be involved in anti-racism work. But if it's going to be an element of organizational transformation, then leadership must be involved, and they must be championing this effort. So the committee then led a process to revise the organizational identity statement and the strategic plan. So they worked with over 300 internal and external stakeholders and gathered very extensive feedback and had a number of listening sessions to really produce a meaningful identity statement, which I'll read to you in the next couple of slides, that they felt is really representative of employees and Boston residents. They also conducted an all-staff survey to better understand staff perceptions of issues related to race and racism, which I alluded to earlier is really a key and important step. So I wanted to really kind of highlight here that they use their strategic plan to set standards for the organization, which is the normalized part of the framework. And I would really say this is the paradigm shift in their approach. It's their strategic plan. And so I decided to read you a few excerpts from the preface and also their vision within their strategic plan, because I think for a public health organization, this was very powerful as taking an anti-racism approach. So they state, in the United States, racism plays a significant role in creating and perpetuating health inequities. Discriminatory laws, policies, and practices have historically denied people of color the right to earn income, own property, and accumulate wealth. On average, Boston residents who are white enjoy better health than many residents of color. These significant differences in health outcomes between residents of color and white residents are systemic, avoidable, unfair, and unjust. And on next slide, I've stated their vision. So they state, the Boston Public Health Commission envisions a thriving Boston where all residents live healthy, fulfilling lives, free of racism, poverty, violence, and other forms of oppression. All residents will have equitable opportunities and resources leading to optimal health and well-being. So again, at this point, I want to highlight that they got organized based on the framework. They developed a strategic plan to normalize racial health equity within their organization. And so, the next step would be to operationalize, which they certainly did. So the first component of how they operationalized is they developed racial health equity training for their staff. So they have a professional development series, which is a core part of the overall initiative, and it actually grew out of requests from staff for content knowledge and training. So I thought this was really interesting. Clearly, I don't have access to the survey, but clearly in the survey, they asked the staff, like, what would you need to be empowered to address racial equity? And so the staff requested training. So the senior leadership required all staff to participate in at least 22 hours of professional development focused on racial justice and health equity. But I think that what's really great is that although it's mandated by the senior leadership, it was driven by employee request. So the staff are required to attend a 14-hour core workshop and at least 8 hours of follow-up workshops, which total 22 hours of professional development. The other aspect of operationalizing is being data-driven. So now, important also to mention that they were already collecting race-based data as far as I could find, but they moved on from that to developing the Boston Health Equity Goals, which I've listed here. Were created with the objective of reducing overall rates in obesity, low birth weight, and chlamydia by recognizing and addressing the racial inequities that exist in that city. They developed work plans for the staff with SMART objectives in mind, and they did it in consultation with internal and external stakeholders. They created impact measures and committed organizational resources to this work. Now, of course, evaluation is a critical element of operationalization. This figure from their report provides a timeline of what they did and what they planned to do. At the time of their first report in 2015, they were preparing to evaluate their processes and practices as seen in red in this figure. They planned for the establishment of a performance management system to train staff on quality improvement methods. I'm not certain if they have completed these next steps, but I certainly look forward, to their next report. But what they do report on is, essentially excellent. Overall, this was the best example of organizational transformation that I could find for a public health organization, because they were so thorough in their approach to this work, but also very transparent in reporting it. So there might be other organizations out there that have done phenomenal work, but this organization was really great at being transparent and providing knowledge transfer on what they did. So for my next case, I thought I would give a Canadian example. I'm sure many of you are thinking, okay, but what about Canada? So I do have a Canadian example, and I'd like to talk about Ontario's new anti-racism directorate, which Sume also mentioned briefly. So the establishment of this new governmental agency was influenced by community advocacy, notably the Truth and Reconciliation Commission, Black Lives Matter Toronto, the Color of Poverty, Color of Change, and a number of groups that are listed here that were acknowledged by the Anti-Racism Directorate. It was established in 2016 by Premier Kathleen Wynne, and it leads the government's anti-racism initiatives to build a more inclusive society and works to identify, address, and prevent systemic racism in government policy, legislation, programs, and services. So I'm just putting this slide here to remind you that I'm using GARE's framework for strategic change. So again, normalize, organize, and operationalize is the lens that I'm using as I describe the Anti-Racism Directorate. So similar to Boston Public Health, they started by getting organized and engaging in stakeholder and community engagement. So they conducted 10 public meetings across Ontario with over 4,500 Ontarians who participated either online or in person. I can testify to that because I was there for the one in Regent Park here in Toronto. And so they summarized the community feedback as having 3 themes. One is that anti-racism legislation was needed to ensure longevity and sustainability of anti-racism work within the government. The second was the need to mandate race-based data collection and public reporting. And the third was the need for government action to address systemic racism in education, child welfare, health, and justice sectors. Their next step was to normalize racial equity and develop a strategic plan setting new standards for anti-racism action for the province. And so their strategic plan, so you see it here on the right, it's a 3-year anti-racism strategic plan, has initiatives under 4 categories. So the first is policy research and evaluation. Essentially, that's the race-based data collection and also developing an anti-racism impact assessment framework. The second is sustainability and accountability, which includes anti-racism legislation, which I'll come to in the next slide, as well as publicly reporting on progress. The third is public education, and with that, they have developed a consultation group and plan for annual conferences in the province that will focus on anti-racism. And then finally, awareness and community collaboration, and within that, there are population-specific strategies. So there's an anti-Black racism strategy, with an Ontario Black Youth Action Plan included. There's an Indigenous-focused anti-racism strategy. And the third is really interesting. It's an Ontario Public Service anti-racism strategy because they received feedback from their staff that racism or systemic racism certainly is an issue within the government of Ontario. So part of their strategy is addressing systemic racism internally. So I would say that for the Anti-Racism Directorate, their major paradigm shift was in the operationalized category because they mandated the collection of race-based data in the province of Ontario. So the Anti-Racism Act passed in June 2017. It requires the Government of Ontario to maintain an anti-racism strategy that aims to eliminate systemic racism and advance racial equity. Section 6 of the legislation requires that the minister establish data standards that provide for the collection, use, and management of information, including personal information, to identify and monitor systemic racism and racial disparities in the province. There's also, so within the race-based data collection, I would remind you that within the strategic plan, they had identified 4 priority areas: child welfare, justice, education, health, and mental health. And you'll notice that I struck out health and mental health because, unfortunately, at the time that the legislation was passed, they included an exclusion related to health information custodians. So the Ministry of Health is exempted from the collection of race-based data. The good news is that I hear that there are some discussions taking place to address this or work around this, but as the legislation stands right now, health is not included. The legislation also mandates a racial equity impact assessment, and so my understanding from speaking or communicating with employees within the Anti-Racism Directorate is that they are in the process of developing a racial equity impact assessment. So, I mean, it is still very early days for this directorate, but this is the first of its kind in Canada, and I would say the future looks promising. Now, I know I delivered some bad news regarding the collection of race-based data in health, so I thought I would also give a brief example where there is some collection of data that's happening in certain parts of Ontario. So Mount Sinai and the Toronto Central Local Health Integration Network are engaging in the collection of race-based data and other equity data in healthcare. So in 2013, the Health Equity Office of Mount Sinai Hospital developed a questionnaire to collect health equity data at the point of care, which is now extended to the Toronto Central Local Health Integration Network. So it's regional. Essentially, all the downtown Toronto hospitals and community health centers are collecting demographic variables related to the social determinants of health, including race. They're listed up there in the slide. Their motto is, "We ask because we care," and they provide training, videos, tools, and resources publicly on their website for collecting health equity information. And I've included the website there. It's very easy, torontohealthequity.ca, or you can Google Toronto Health Equity. Although I couldn't find very much with regards to the organize and normalize aspects of the framework, they have been successful in operationalizing and being data-driven. So within that, I also wanted to highlight the work of Mount Sinai Hospital, which is the leading hospital in this work, or the hospital that is leading this work. They've also taken steps to collect data on their staff with regards to race and other demographic information, as well as cultural safety and inclusion, which they call their workforce census. They have a commitment to equity as a core value on their website. And they have a number of internal and public campaigns and activities empowering staff to be an ally, as you see on the right, and to address different forms of discrimination and harassment in the workplace. Again, these resources are also available to the public. In fact, I thought it best to include a few of their tools here and other Canadian and American resources that focus on racial equity. So here I've listed a few for you. So that's here for your future reference, since these slides are going to be available publicly for future reference, and this recording will be available online. So feel free to look into those resources, but I highly recommend them, and they are quite informative. So in summary, I'd like to just say that institutional racism is an ecological form of discrimination, and it is a social determinant of health in Canada. Public health organizations should, and health organizations in general, should engage in evidence-informed approaches to achieve racial health equity. These generally involve recognizing the societal harms caused by systemic racism as a first step. Certainly it involves strategic planning and change management for organizational change, and that also requires leadership, at the very top. And then a critical piece is the collection of race-based data within and outside the organization. Also, the Government Alliance on Race and Equity, known as GARE in the United States, has tools and resources for leading strategic institutional change which I listed on the previous slide, and the Boston Public Health Commission and the Anti-Racism Directorate are great examples of organizational transformation to address racial inequities. Thank you.
Thank you very much, Onye, for that presentation. I found it really informative, and I do think the example you shared, particularly the Boston example, is a really comprehensive one. So definitely encourage people to check it out. Just as a reminder, a number of people, I think anywhere from like 35 to 40% of people said they're currently doing work on anti-racism, and that your organizations have this as part of your work. So I'd encourage you to share any resources that you are developing with us in the chat box so other people can access those. So thank you. I see a number of people are already sending in questions. So please continue to do so. We'll now move to the questions, and Onye, so I'm just going to read them out, and we can both tackle them. I'll let you go first. So our very first question is about the relationship between racism and social exclusion. So the question is, how do you see racism in relation to social exclusion? Are they similar?
Are they similar? I can't see the question. Right.
So the question is, how do you see racism in relation to social exclusion? Are they similar concepts?
I see racism as a mechanism that causes social exclusion. I mean, so where we think about marginalized groups or marginalized individuals, but particularly groups, if we're thinking using a population lens, it's through racism. It's through, first of all, the development of even having race, and the race is a way to have hierarchies that are based on nothing but a social construct. So it's not based on biology or anything like that. It really is a social construct that was created to create a situation or a social situation where certain groups, in particular, white Europeans, are superior to other groups. So where all the other groups become other and experience otherness, and as I mentioned, it's throughout the life course, then of course that leads to social exclusion, at least from the dominant culture, right? Within subcultures, of course, there can be feelings of belonging and inclusion, but where we're talking about the dominant culture, then certainly that the result is social exclusion.
Great, thank you for that. So I'm going to keep going here with the questions. So there are a number of data-related questions. I'm thinking we could probably sort of address them together. So the first is, are there examples of cross-sector models for mobilizing identity-based data collection to address equity issues across populations as opposed to sector or health specific? So really, are we working together in terms of our data collection related to race and racism? So let's just start with that. So race-based data collection.
So having it not at the, so aside from it being at the sector level, having
sectors work together.
Yes, I'm not, so I don't know that I can speak to that as far as sectors working together. I think what the Anti-Racism Directorate is doing, mandating this work, because there's a resistance to collect this type of information. Some of it is because organizations are, concerned that it's actually racist to start asking people about race, right? There's also the myth that in Canada, we don't have racism, that this is a very multicultural society where everybody has, equal access to opportunities. And then there's the other piece that, again, you can't manage what you don't measure, but if you measure it, then you also have to manage it. So I think the first step of where we are, at least in Ontario, is mandating that sectors collect it. Ideally, I think we would move beyond that, but at this point, I mean, it's been really, a long journey to even get here. So I think realistically, this is where we're at, but ideally, that would be a great direction to head in.
Great, thank you. I can't think of any examples of cross-sectoral data collection either, but I do think there's some opportunities and interesting work happening. So as an example, Toronto Public Health staff were very instrumental in developing the Anti-Black Racism Action Plan for the City of Toronto. And that plan does include some action items related to data collection. So as a city or a city department, they could decide to work together to do that cross-sector data collection. Now, I have no idea what they're actually planning on doing, but the point is that there are opportunities for us to think about how we do that and the benefits of that. Another opportunity, I think, is there's a lot of adaptation of what happens in other sectors. So the education sector has been doing a lot of work around related to anti-racism for a very long time. So that's a sector for us to look towards. They're not perfect by any means, but there's been that concerted effort in certain educational institutions so that can provide some guidance for public health.
And sorry, I did see a comment earlier where somebody said, mentioned
clarification about the staff training at Boston Health. The question is, does the senior leadership also attend the 22 hours of education?
Oh, yes, they do. The senior leadership also engage in, all staff engage in the 22 hours. And they also, I couldn't get into a lot of details, but they also have, so they build capacity. There's also staff training. So different staff members can go through a special training, which is an additional number of hours, and there's actually kind of like a role description, and they apply for it to become facilitators as well. So they have a quite comprehensive approach to that, and as well as a very comprehensive evaluation. So again, due to time, I didn't get into it, but they have pre and post assessments that occur right after so before the session, right after the session, 1 week after the session, and then 6 months after the session. And then they also do random interviews with staff who have participated in it and engage in a whole CQI approach to the workshops. So it's actually very intensive.
Thank you. So there is a very interesting and relevant conversation happening in the chat box, which we will get to very shortly. Just staying with the data a bit, and I think this is an interesting one to explore. The question is, regarding race-based data collection, how would you deal with people who identify as multiple races / mixed race? So I really think that question is, I think it's a bigger question. The question is, how do we identify people? And Onye, I think in her previous response, mentioned that a lot of us think that asking questions about race itself is racist, which is a very powerful way in which we end up not doing anything about racism as a problem. And just to respond to some of the comments coming in there, the idea of race is definitely not archaic. What is archaic, in my opinion, is race as biology. That is what is archaic. It was never real. It was invented. Now, race may be a idea, but the consequences of being racialized are very real. So the consequence of racism, the everyday discrimination, the systemic and institutional discrimination are definitely very real, and I think that's what our webinar today is about. We see the realness in unequal opportunities across every single sector. We see it in inequitable health outcomes, in life expectancy. So pretty much any issue we can think about, we tend to see those very explicit racial inequities. So I think that's when we're talking about race, in the context of this presentation and the context of our work as people concerned with health equity and social determinants, we're really thinking about race as a biological idea, which is why it's very important to focus on racism as the problem, right? So thinking about, again, how those systems and practices create the inequities we observe. Just a general principle, so I think in terms of defining people, I would believe that we should define ourselves. So I saw a question, who says what race you are? Typically, the way in which we create racial inequity is mainstream society says what race you are. So we have decided who is black, who is white, who is not. Those criteria are constantly changing. So I love these examples of South Africa, Brazil, and North America. My cousin's father is Cameroonian, so he looks like me and black, dark skin. Her mother in South Africa is considered colored. If her mother was in Canada, she will pass as a quote-unquote mixed-race person. In the South African context, when my cousin fills out surveys, she's forced, not chooses, but she's forced to pick the other box. So I'm using that as an example just to demonstrate that different societies construct the idea of race, right? And in different places, what race you are tends to be determined by mainstream society in terms of how it impacts. For our purposes as
and can I weigh in when
practitioners, absolutely. So for our purposes as health practitioners, I believe that we should be asking people to self-identify. So we should not be imposing definitions of race on people, so people should identify. And more importantly, we should start to look at the systemic aspects of racism. So there's been some interesting work going on, since examples coming out of the U.S., where they're actually measuring institutional and cultural practices as proxies for systemic racism, as much as how I identify, but also how our society, what those policies are, which, as I mentioned, create those racial inequities we see. So I hope that answers some of the questions, but please continue the conversation in the chat box. Yes, Anya, you can respond to that question too.
Yes, so, well, I think there are two pieces to it. So one is, first of all, I absolutely agree that people need to self-identify with regards to race, and oftentimes it can overlap with ethnicity because race is a made-up construct, as you said, right? So, you know, for somebody who is South Asian, that can be considered their race and also their ethnicity. But it is important when you're asking the question to know what it is that you're trying to measure, just like anything else where you're asking a questionnaire. There is also evidence, and I would strongly recommend this article. So it's called Using Socially Assigned Race to Probe White Advantages in Health Status. And the author is Dr. Kamara Phyllis-Jones, and it was published in Ethnicity and Disease in autumn of 2008. So Camilla Jones, I believe, is now the president of the American Public Health Association. But in this paper, they asked people about the race that people thought that they were. And that has more, there is more correlation with health outcomes, at least in the United States, with regards to what race people think you are. So if, for instance, you self-identify as being African American, but you look white, particularly with regards to whiteness, so it's white advantage, your health outcomes were more associated or closer to the white population because race is how people treat you. That being said, it doesn't mean that the gold standard is people looking at you and assigning race, like when you, at point of care. That's not a good practice either. What's considered best practice is that the person self-identifies, but then is also asked a question akin to how do other people perceive you, or what race would other people say that you are, and so that is predictive of health outcomes. Again, particularly with the association with whiteness, or the appearance of looking white. The other piece around mixed race is, I think that's a whole, it's a discussion in itself, but I just wanted to flag a couple of interesting things. So one is, I know that for what's being done here in our hospital in Toronto is you're given a number of categories and you must choose one. So you have to choose the race that best describes you. So you can't check multiple boxes. One of the options is checking multiple boxes. What's interesting is that I know that Akwasi Owusu-Bempah, who's a criminology professor here at the University of Toronto, who's done a lot of work looking at racial disparities and inequities within our federal prison system, and also with regards to policing, is starting to look at what appears to be an increased risk of incarceration seen among biracial black males, or biracial males, so half black, half white. And you know, in conversations with him, he even suspects that some of this is due to kind of another level of social exclusion where they don't quite fit into the white world and they don't quite fit into the black world, or feel they might need to prove things. He doesn't know, but there seems to be increased risk or certainly increased relative risk with the biracial population in our prison system compared to their representation in the general Canadian population. So I think that's something that needs to be explored further, but I don't have the answers.
Okay, thank you for that. And for people asking, we will share that that article by email following the webinar. We'll also include some examples of how are being addressed in the Canadian context. To that point, Smash mentioned that there are technical reasons why it makes sense to have options. So why, as much as we don't want to put people in boxes for the purposes of matching data to things like census questions and things like that, there are technical reasons why it makes sense to then have categories. So we will share some of those examples. So I'm going to go through to more questions and see what we have there. I'm going to read out a comment. So I think it's a really good clarification. So the comment is there's some biology to race, and in the sense of phenotypical, like we look different, that's just a fact. Now the social construct is the meaning that is attached to, in this case, the brownness. So it's important to make that distinction when we talk about race as being socially constructed.
Sorry.
Thank you. So we do have some more time, so please do keep the questions coming in. Sorry, Onye.
Can I comment on that? I think it's really important for us to explore that. Sorry, Sume, I can't hear you.
Yes, so you would you like to respond to that comment?
Yes, yes. So, I mean, it's really important, particularly in health, to kind of discuss this. So definitely we're talking about people phenotypically looking different, but are not actually different categories. Phenotype can be like we're talking about tall people versus short people. But what has happened is that there is an assignment, as you said, not only based on what it means, but making assumption that they also have common characteristics. So I give you the example of, sickle cell anemia, which is a genetic condition that sometimes gets labeled as being a black genetic condition. However, it's not all of Africa that is affected, or even all of sub-Saharan Africa that is affected by that gene. And so people look at phenotypes of patients, and a patient could be from East Africa, where there isn't very much sickle cell, or South Africa, where there isn't very much sickle cell, and assume that they might be at risk because we look at that phenotype and make a lot of health assumptions based on it. The other thing is, by doing that, we also miss opportunities to screen people who might be Mediterranean or Indian or from the Middle East who might also have sickle cell. So I think the problem is, where I say it's not biologically based, is that phenotype, again, like whether people are tall or short, was used to make a lot of different assumptions about people's cognitive ability, their medical conditions, and overall their potential and worth in life. So it's a matter of it being a confounder and confusing things, particularly in medicine, where we think that race is biologically based and it's real. No, it's a social construct. And so it's important to understand that. Now, it doesn't mean that there aren't conditions, like I mentioned, sickle cell, there's issues with prostate cancer, but those are based on ancestral regions. So again, it might be West Africa or Central Africa. We have to look at where people are from and the genes that might be in that environment, and not make an assumption about genetics based on the fact that somebody has dark skin or brown skin or a straight nose or a wide nose or kinky hair. It's actually absurd and dangerous, but it's what we do.
Thank you for that, Onye. Okay, so I see we have some more questions and comments coming in, so please keep those in. Just going to check if we have more. So there's a question which is, how do we move from race-based data collection to coordinated action to address inequities at systemic levels for entire populations rather than individually motivated organizations? So really the question is, how do we work together to address racial inequities at a systemic level? Onye, do you want to start?
Okay, so I was hoping you would start.
I was going to start by saying that's the entire webinar.
Yeah, no, I think
I can go ahead.
Okay, I think it's complex, but I think actually I like I wasn't able to kind of pull this from the article that I mentioned in the Lancet, but basically they mentioned that the racial inequities that we see today and the disparities that we see today, a lot of them, the root causes of that have been within government, and government kind of legislating people, segregating people, colonization, the whole thing. And so government has, not just a moral or, it's a good thing to do, but actually has a strong responsibility to correct the wrongs that were done in the past. So I do see, the need to kind of, for all of us to work together. But I think a lot of the disparities that we see today that are, socially driven have their roots in, decisions made by those who had the power to create legislation. So I think that's a first step. For everything else, I think that might follow, but I think that's still one of the major root causes. How to do it beyond kind of legislating and working with different sectors and mandating changes, again, I'm not sure how to do that. I would assume that one kind of follows the other.
Yeah, absolutely. And I think your point around the responsibility of government and of the state is a really important one. During the last webinar, our presenter on that call, Dr. Ingrid Waldron, talked about the idea of state-sponsored racial violence, right? And her argument, which I agree with 100%, is that racism exists because government, largely because government let them exist. So either through very explicit actions, so we can think about things like the Indian Act, which continues to exist and functions as a tool for racial oppression for Indigenous people, and through things which the government just fails to do. So I think that responsibility for our political leaders, our leaders within organizations, to make it a priority is really important. Generally, I don't think this issue can be addressed by one sector only, but I think sector-specific responses are also very appropriate. So in public health institutions within the health sector, we need to start to figure out or continue to address, to take those actions within our organizations, and also work with other sectors where the opportunity exists. In terms of specific approaches, a number of public health organizations are now engaging in sort of collective impact as an approach. So it's really an approach that brings together different sectors to work on a common issue. And we've done a little bit of work in that area, and we can include that. But I think collective impact is just one of many approaches we can use to work together. Okay. So I think we have time for maybe one or two more questions or comments, but if you do have more, you can send them in, and if we don't get to them on the call, we'll do our best to address them in a follow-up email. So this is a question, Anya, I'm going to let you tackle this one. It's about the Toronto Central LHIN. So we know that they've been working with other organizations to collect race-based data. Do you have a sense of what kinds of policies and programs they are developing in response to the data they've been collecting?
So the last I spoke to them was a few months ago, maybe months ago, where I spoke to the equity group. They were still at the point, so they have a report online where they've engaged in the data extraction and reported on how it was collected. My understanding is it's still, everything's still at the analysis period and not at the time of significant action. So I'm not aware of any new policies that's happening within the Toronto Central LHIN that's solely based on the data. It's still fairly early days for them. That's from the information that I have from 6 months ago.
Okay, great. Thank you for that. Okay, so we're going to just move on. As I said, if you do have questions, you can keep them in. this one. So this is a question about intersectionality. The question is there a challenge with addressing social determinants of health for multiple marginalized groups, e.g. addressing intersectionality, while being sensitive to the nuances of different experiences of oppression for multiple groups?
So I can speak to that. So I think it is a challenge. And even with, the American Civil Rights Movement, it was a challenge where, now when, groups like Black Lives Matter kind of reflect back on the Civil Rights Movement, how it was very centralized and focused on, male heterosexual experience, groups like Black Lives Matter have kind of been very intentional about decentralizing and addressing intersectionality. So if you, read the Black Lives Matter webpage, there's a lot of emphasis on intersectionality. I think that often gets lost. But I have been able to attend, training sessions on cultural safety where, privilege and power and all of these concepts are really broken down quite well so that one gets a sense of intersectionality. One, even for me as a Black woman, I am a physician, and in certain situations I have privilege and power compared to my patient. But there are other situations that, because I'm a woman, because I'm Black or a woman of color, I don't experience that privilege. But being self-aware about it within ourselves, and then being aware of our situation with other populations and other people that we're dealing with is really a key component in that reflection in cultural safety. How that is reflected, at large policy levels, or as we're talking about sector level in government, I think is a little bit more complex. But certainly at the training level or the interpersonal level, that can be addressed.
Thanks for that. And there are people within the public health sector looking at intersectionality. And I do think in practice it can be a difficult thing. I also do think it is absolutely essential, which is where the population-specific interventions then become important. Because the fact of the matter is people are experiencing policies and programs in very different ways. And I love the quote by Audre Lorde. She says, there are no single-issue struggles because we do not live single-issue lives. So for people who are living at the intersections of multiple systems of oppression, that it becomes very, very important to make that very unique experience central to the kinds of interventions and policies we develop to change the situations those communities live in. So it is possible. Again, we will make a note and include some reasons. So I'd like to thank you all for attending today. I'd like to thank Dr. Onye Nnorom for being on the call and sharing your great expertise with us. To all of you who asked questions, stayed on the line, shared resources, comments, thank you so much. You can find out more about racism and other health equity-related issues on the NCCDH website, and also resources on our resource library and in our health equity community and organization. I believe we have a link to our evaluation. There we go. You can click on that link right now and complete the evaluation form and provide us feedback for this event. As I mentioned, this is the second of a two-part series on racism. We are very aware of the fact that there's so much to cover in this area, so we'd like to hear from you about what other areas you'd like us to explore related to this. So thank you all for being on the line, and I believe you can contact us if you have any questions following the webinar, and as I mentioned, we will be following up with some more resources. So thanks again, Anya, for being here. Thank you, Danielle, for ensuring that everything went smoothly today.
Thank you for having me.
Hey. Bye, everyone.